Hi, I'm Dr. Shomit Ghoshal, consultant endocrinologist, Nightingale Hospital, Kolkata, India. Myself and on behalf of my co-author, Dr. Binayak Sinha from AMRI Hospital, Kolkata, India, we would like to present the MARK-2 analysis for IDF 2021. Now, to put things in perspective, the reason why the MARK analysis was done initially, and now we are presenting the MARK-2, is because we have seen a paradigm shift in the management of type 2 diabetes from being glucocentric to being outcome-centric. We do have molecules which make a difference in the cardiorenal outcomes, especially the SGLT2 and the GLP-1 receptor analogs. Now, how do we mix different molecules and keep a disease-modifying drug along with a glucose-lowering drug? In order to do that, most of the guidelines tells us today that we need to do risk assessment. And this risk assessment means we need to assess every single diabetic patient that we see in our clinic from the cardiovascular perspective, whether they are at high risk of atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. Now, the issue is how do we do that? Qualitatively, the ESC tells us we can do that by just enumerating the number of comorbidities that they have, including their anthropometric measurements, their BMI, the age, and we can look at the additional risk factors like hypertension, dyslipidemia, and then we can classify them as high risk or very high risk. But quantitatively, it can be done with the help of QRISK 3 risk engine. And this is validated for type 2 diabetes and as well as for the patients of Indian subcontinent or ethnicity. So what we can do is to find out whether QRISK works as well in the Indian subcontinent, patients of Indian subcontinent, or do they have some difference from their Caucasian counterpart. To do that, we did initially the MARK analysis, where we collected data from 1,538 patients from all across India, dividing India into 5 zones. And we saw the validity of QRISK 3 in the population, and that was the MARK analysis. The problem that we faced is that for a busy clinician, it is extremely difficult to put 21 inputs to get the output in the form of high cardiovascular risk. And that's a problem with QRISK 3 risk engine. We have to put in 21 inputs to get the answer. So in order to simplify it, we thought that let us try something out on the same database that we collected using the same risk that we stratified with the help of QRISK 3, and whether we can go ahead with the dimension reduction using machine learning, taking into consideration those 21 factors, and we bring it down to some reasonable working number, which we can easily negotiate in a busy clinical schedule. So to do that, we divided the entire data set into training and testing sets, dividing into 80 and 20% respectively. And then we use the XBoost algorithm to find out which exactly is the model which is going to work for us. We need 29 iterations to get the exact model on which the training data was first tested upon, and then it was validated using the testing data. And we could use this and employ the machine learning algorithm to reduce the number of dimensions without sacrificing the precision and accuracy. So that was the whole backdrop point. And we could zero it down to 10 important clinical parameters. For example, as we can see from the figure, age, smoking status, the gender, then we had whether someone had hypertension or on antihypertensive therapy, dyslipidemia, the LDL and the total cholesterol and HDL ratio, the presence of CKD. So we could have these 10 clinical parameters which we routinely assess in clinical practice. And hence, this is our presentation as MARK-2, that the QRISK 3 risk assessment, which is already validated in type 2 diabetes with 21 parameters, we, with the help of the machine learning approach, could bring it down with the help of dimension reduction to 10 parameters. And we intend putting this into further epidemiological testing. And if it is validated, we could then develop a simple algorithm and a simple tool which the clinicians can use in their busy clinical practice and make this risk assessment much faster. With this, we'd like to conclude, and I'd like to thank the organizers of IDF for giving us an opportunity to present our MARK-2 analysis. And I also like to thank Dr. Kingshu Porchach, who helped us in preparing this e-poster, and PharmAge, who helped us in collecting this data from all across India.